more about that on the next webinar when we start talking about some of the more advanced designs that are available on the Atlantis platform. But that's one niche I found in my practice where I could really grow my scleral lens portion was in that presbyopic marketplace. You've probably also heard about ocular surface disease. Patients with severe dry eye do very well with scleral lenses because we hold a moisture chamber on that eye all day that can actually heal and treat that cornea, and we protect it from the environment through the large surface area of the lens. It works good for patients with severe dry eye, obviously Graft-versus-Host, Sjogren's, Stevens-Johnson, those types of things. It also works really well for people with mild to moderate dry eye who just can't wear soft contacts, who suffer dehydration issues. Putting them in a scleral lens offers them great comfort, and scleral lenses are gas permeables in a sense, and they can't dehydrate. There is no water content to them. So another good application in the normal cornea realm for scleral lenses. When we talk about sclerals, no matter what design we're talking about, we always have to look at three areas. The central zone is where we're going to vault over that cornea, and with this design, we're going to look for about 300 microns of vault when we start out. The limbovault zone is the area we can manipulate to make sure we don't touch the limbus. And then finally, the scleral zone is what actually rests on the eye. And we need that to rest nicely and evenly, not impinging, not lifting off. And we'll go through all of these step by step. 300 microns was chosen for this design, for the central zone, for a few reasons. We're still learning a lot about scleral lenses, about oxygenation to the cornea, where we get that oxygen, and what the right vault is. These lenses all settle, especially this design, about 100 to 200 microns throughout the day. And so 300 microns is a really good starting point because it allows that up to 200 microns of settling, leaving still 100 microns of clearance over that cornea. You got to remember, whether this is a graft patient or a keratoconic patient, typically the steepest portion of that cornea is the most diseased. So what we want to do with this is avoid touching or disturbing the most diseased part of that eye at all costs. And that involves vaulting over that area. So 300 microns is enough room to allow for settling. We don't want to go a whole lot higher than that, though, because then we start really limiting the amount of oxygen we get to the cornea. We all know the cornea gets its oxygen from the atmosphere, and it has to diffuse through the tear film. In the case of contact lens wearers, whether it's a soft contact or a scleral patient, it has to diffuse through the contact as well. Well, with scleral patients, is a whole other aspect to that. The scleral lens itself is always going to be a higher hyper-decay material, so permeability is usually not too much of an issue through a scleral lens. So designs are also getting thinner, allowing lower decay over T values, transmissibility values. But what we have to remember is we also have a 300 micron tear film behind that lens, and the decay of water is usually about 80, so that's going to be our limiting factor there. And the thicker we make that vault or that tear layer between the lens and the eye, the less oxygen we're going to be able to get through to that cornea. I saw a stat recently, it was in a journal article that said when you go from 200 microns of vault to 400 microns of vault, you'll reduce the oxygen at the corneal surface by 30%. So it's pretty significant to make even a small increase in vault. So 300 is kind of a happy medium, but at the end of the day, you'll be closer to 100, which is really ideal for getting oxygen to that cornea. So if we think about wanting 300 microns of vault over every cornea out there, right, tall, small, steep, and flat, we're going to need very different sagittal depths in order to accomplish that. If you look at the pictures down here, this one in the bottom right has a lot of sagittal depth. It might be good for getting 300 microns of vault over a very ectatic cornea, right, a very severe cone. Whereas this flatter lens with less sagittal depth might be good for getting 300 microns of vault over, say, a post-RK cornea that's sort of collapsing on itself and is very, very flat. So we have to be able to manipulate sagittal depth in order to get that 300 microns of vault. And we're going to get into photos, and I'll show you exactly how to measure that 300 microns. But we're going to kind of start from the beginning here. So there's two ways that we'll go about affecting sagittal depth in order to get more for a steeper cornea and less for a flatter cornea. The first way and the most common way we'll go about doing this is by changing the base curve of the contact. And it's very intuitive. A steeper base curve is going to give us more sag. So the steeper the base curve, the higher the sagittal depth will be. So a more advanced cone will require a steeper base curve scleral lens than a post-refractive cornea that will require a flatter base curve. The thing you have to remember about sclerals is that these are essentially prosthetics, right? We're giving these patients new corneal surfaces with which to refract light, and we want it to act and function like a normal cornea. Well, if we get a really ectatic eye, we can steepen that lens base curve wise, as steep as we need to go in order to get over it by that 300 microns, right? We can go up to a 610 base curve, a 590 base curve. I remember back when I was fitting the Jupiter lens back in the day, I think I fit a 550 base curve at one time. I mean, that's 58, 59, 60 diopters. And if you think about that in terms of K values, there are no normal corneas out there that are going to have 55, 57, 59 diopters of power as a K value. So that's not a normal cornea that we're offering that patient. So in those circumstances, when we need a lot of sag and we don't want to go too steep in base curve, our second option is to increase the diameter of the contact lens. Small increases in diameter give us really big increases in sagittal depth. So that allows us, by simply making the contact a little bigger, to keep a more normalized base curve. That reduces aberration, allows a more normalized viewing experience. Also takes a lot of minus out of the lens. Steep add minus. Remember the old Sam Fapp rule. So these steep lenses will require a lot of minus, like you see in a lot of corneal GPs for keratoconics. Scleral lenses tend to have much more normalized powers, -4, -6 range, even for some of the more advanced cones that you'll see. So we didn't set up the poll question, so you can't answer this in any way through your computer, but we'll go over it really quickly here. And it's just what we talked about. What are two ways that we can increase the sag of a scleral lens? In other words, to get more vault, to get over a steeper cornea. And obviously the answer, like we talked about, is C. We can either increase the diameter or steepen the base curve, or both. So let's jump into the Atlantis fit set here. The Atlantis fit set, I want you, there's a lot of numbers on this page. Ignore all the numbers on the right side. Just focus on these base curves right here on the left and the corresponding letters. You'll see we have 5 15.0 diameter base curves, and then we have 3 16.5 larger diameter base curves. What's unique about the Atlantis set is that we don't care what the cornea, the topography, the Ks look like coming into the fit. We're going to put the C lens on everybody. The C lens is a 767 base curve, 15.0 diameter with a -3 power. And that's going to go in every single patient. And the reason for that is because when they were designing the lens, they found this, and I can attest clinically, about half the patients you put that C lens on, whether they're regular or irregular, will end up in that C lens. So you've got a coin flip chance of leaving a patient in a C lens when you put them in that to start with. So we always start there. And then from there, we either work up or down. If we put the C lens on, we say we don't have 300 microns vault, we have less. We have insufficient vault. Whether that means the lens is resting on the cornea or it's just not enough vault, we're not at 300 microns, we simply need to steepen the base curve, like we just went over. So we'll move to the D lens. That's 2 diopters steeper. You can see the sag increases there. If we still have insufficient vault, we go to E. If we still have insufficient vault, we can go to F. And when we go from E to F, as you can see, we go from the 15.0 to the 16.5 diameter. We still increase sag, as you'll see here. But you can notice we actually flatten that base curve 5 diopters. That's because that little 1.5 millimeters of increased diameter gave us so much sag. We were able to flatten our base curve, never make it steeper than a 703, but still have a nice step up in the amount of sag that we have to get over those steeper corneas. We put the C lens on and they're a post-RK patient and we have excessive vault, we have way too much, we can simply go the other way. We can flatten down to a B, and if we need to, down to an A, taking 2 diopter steps in either direction. Sometimes you'll find that a C might have not enough vault and D might have too much vault. You can always split the difference. Between a 46 and a 44 is obviously a 45 diopter, and you just account for the difference in power, steep add minus, flat add plus, obviously. But most of the time you'll be able to fit right out of this fit set here and do so pretty easily and pretty effectively. Inserting scleral lenses is really not difficult, especially if the patient's worn contacts before. If the patient's worn contacts before, I've got a good tech, and she can give them an INR in literally 10 minutes, and they'll never have a problem. They'll never call our office with issues. If they've never worn contacts, a scleral lens is going to be difficult, just like a soft lens might be difficult. And it takes time and it takes encouragement. But the big thing to remember is that we have a 50 micron tear film naturally on our eyes, on a normal patient. And we have a 300 micron vault between the lens and the eye. We cannot have any air in there. So we have to fill the lens up with saline before we insert it in order to fill that gap in there. We have to use preservative-free saline to do that. If we use any even mildly preserved saline like Bausch & Lomb sensitive eyes, it'll be in contact with that epithelium all day. It'll eventually start to irritate the eye, and it's going to affect wear time. If I know the fit's right and the patient comes in and complains about decreased wear time and red eyes or something along those lines, the first thing I ask is, what do you fill the lens up with, or did you rinse the lens all the way off before you put it in? Has to be completely preservative-free. I've got a slide later with some options as to what we can fill that lens up with. There used to be only really one option, and in that now we have a whole bunch of them, both on-label and off-label. They're very convenient, affordable, and effective for filling that lens up. I have the patient lean forward like the lady in this picture here. I have them tuck their chin into their chest. I'll have them pull their lower lid down. I'll lift the upper lid up and I'll pop it right onto the cornea there, face parallel to the ground. It's also very helpful for diagnostic purposes to take a fluorescein strip and dip it in that lens bowl, and that's going to help us actually measure or visualize the vault we have over that cornea there. If they do get an air bubble that's anywhere significant in size outside of a tiny little micro air bubble, these lenses do have to be removed and then reinserted afterwards. So again, we talked about we have a central zone. That's what we've been kind of talking about so far with needing that 300 microns of vault, a limbal zone and a scleral zone. We're always going to work inside out. The first thing we always want to set is our central zone. Until then, nothing else will be right. And if we get our central zone set, usually the rest of them fall into place pretty nicely. So again, we put this lens on with the saline that's stained with fluorescein, and we're going to evaluate this with a white light. I know we're using fluorescein. We're still going to use a white light. Our beam as thin as we can make it, as bright as we can make it, and we're going to swing out our illumination source to about 45 degrees, whatever makes you comfortable, and cut it through this system. And what you'll see is 3 bands. The first band is black, it's optically empty, and that's our contact lens. Okay. In between the contact lens and the third band, which is our cornea, is the green band, and that green band is our tear layer. That's our vault. The thickness of that green band will tell us how thick our vault is or how much vault we have over that central cornea there. And that's what we're going to use to find our 300 microns that we're looking for. What's really convenient for us is that our contact lens trial sets will have center thicknesses of about 300 microns. So we know our contact's about 300 microns thick in the center. All we need to do is make our green band or our vault about the same thickness. And when there's a nice one-to-one relationship, like there is here, you know you have a good 300 micron vault over that cornea. They tend to ride a little bit inferiorly, so you'll notice your vault's a little bit higher inferiorly, a little bit lower superiorly. Just focus right on that center when you're first starting out. That's the area that we really care about there. Here's a few more pictures of a good, nice one-to-one relationship between a contact lens and our vault or our tear layer. This middle one's an OCT image. OCT can be very, very helpful with scleral lens fitting. It's by no means a necessity. You can fit, and I encourage you to fit sclerals without OCTs because it's so much more efficient. With these new designs that fit so great out of the box, it almost doubles your fit time to warm up an OCT, get a patient's name entered, take the measurements, print it off, get them back to the room, have a technician available to do all these things, when you can really do it behind a slit lamp very conveniently and very efficiently. But when troubleshooting, when you're first starting out, as a way to check your work, OCT will give you down to the micron exactly how much vault you have over that cornea. And you can see how close you are to that 300 mark. Obviously, when we first put that C lens in, it's not always going to be perfect. So there will be adjustments that have to be made at least half the time. If you look at this image on the left, you can see a very thin contact lens, the optically empty area here, next to a very thick tear layer. And so this tear layer is probably 3 times as thick as that contact, which would indicate excessive vault here. We have too much vault over that cornea, right? That's not going to get enough oxygen to the epithelium. So in this case, we're going to flatten our base curve. If we had the C lens here, we go down to the B lens, which is a 2 diopter flatter lens. And we can go down to the A lens if necessary as well. Picture on the right, you can see we have insufficient vault. You can barely even see a green band here, but it's obviously much thinner than the contact lens itself. So in this case, we're going to need to steepen our base curve. Again, if we're at the C lens, we'll go up to the D in this case, and we can continue to progress up E, F, G, and H, and it's going to tell us when are we changing base curve, when are we changing diameter. That question's already answered for you. You just follow along with the alphabet there. So we'd steepen the base curve, this image on the right, in order to get more vault, to try to get a one-to-one relationship between our contact lens thickness and the vault we have over that cornea there. So again, a few more poll questions. This chart in the center is the fitting set. So here we just say if this is trial lens C that we put in, what would be our next step? And as you can see here, we have excessive clearance. So our green band is much thicker than that contact lens black band. So if we were at C, we'd need to flatten our base curve down to B in order to reduce our vault or reduce our sag and bring it down closer to the cornea for a nice one-to-one relationship. Again, here's the opposite. Sometimes you'll see no fluorescein at all. Sometimes it'll just be the contact resting right on the cornea. That's not ideal, obviously. We want vault. So if this was the E lens, we would need more sag, more vault. We continue down the alphabet from E to F. That will jump us to the 16.5 diameter, which will give us more vault and a nice one-to-one relationship there. So again, it's just, if you know how to follow along the alphabet and you know if you need more or less vault, the fitting set really does the work for you. One thing to really take note of, like I said earlier, we always start with C, so don't let topographies fool you as far as cheating in one direction or the other. You'll be surprised. There's so much more that goes into sag than just K values, right? It's corneal diameter, it's eccentricity values, it's the steepness and the shape of the sclera. It's not just how steep or flat it is on your topography. Topography does really help, though, in deciding, hey, where's the steepest area of my cornea? Because I always want to find that when I'm fitting a scleral lens. I could have a nice 300 micron vault right here in the center if I look at this with my, my slit lamp beam. But if I were to come down here a little bit, I would notice obviously I hit touch, and that's not okay. That's not ideal in a scleral lens. We always want at least 200 microns of vault over every portion of that central zone, 200 microns minimum. So if we do have touch in some area, we do have to steepen that base curve back up. Even if it means we have excessive vault centrally, I'd rather do that than rub on the most diseased part of that eye that's going to lead to corneal haze, corneal scarring, and possibly eventually high drop formation and transplantation. So make sure you're vaulting that entire cornea. Typically with cones, what I found is even if a topography, obviously the cone's usually inferior, look inferior and then cheat nasal, a millimeter or two, and you'll find most cones are actually, even if they don't appear so in topography, are decentered nasally. And that's, I always seek out that apex. I find the apex of my cornea and say, okay, now that I'm at my apex, do I still have enough clearance? Do I still have at least 200 microns after I set my central zone to 300 in the middle there? And if I do, great. If not, I'll go ahead and steepen that lens up again. That's it for the central zone. Again, start with C and then go up or down depending on if you need more or less vault until you get a nice one-to-one relationship between your green tier layer and your contact lens. The next zone is the Limbus Zone. For the most part, with these newer designs like the Atlantis, once you get that central zone set, there's not a whole lot of work to be done in the limbus or on the edge. But sometimes you do have to make some adjustments. In your fitting set, every single lens is going to have a standard Limbus zone. You can manipulate that Limbus zone with one steep, two steep, one flat, two flat measurements. And it's pretty intuitive. The steep measurements will increase your vault in that limbal region. Your flat will decrease your vault in that limbal region. So if you don't have enough vault, you're touching the limbus, we're going to start working in the steep direction, obviously. They only give you about 25 microns per step. There's a new reverse geometry addition to this lens that works really well for oblate corneas that we'll get into on August 1st that can get a little bit more technical than this. But for any cone you ever fit, this is going to be all you need. And most regular cornea, this will be all you need as well. It's very, very simple. I have the patient look in primary gaze, and I look at 4 quadrants. I'll hold the top lid up. I'll look at 4 quadrants with a narrow section, and I'll just basically ask myself, can I see green? And I actually, if you see down here, I actually cheat in just a little bit because these lenses are only 15 millimeters in diameter on a 12 millimeter cornea, meaning we only have about 1.5 millimeters to land this lens once it gets past the limbus. So the vault really runs out as soon as the limbus ends on these. So I'll cheat in a little bit so I can actually see some of that green fluorescein under there. And I ask myself, can I see fluorescein or not? And if I can, I pretty much leave it alone. If I can't, I will jump to a 2 steep usually. And if I'm not sure, maybe I see some, maybe I don't, I'm not really that comfortable, I'll go to a 1 steep at that point. You only make a 25 micron jump, so it's nothing dramatic. I err on the side of steep because I want to make sure I'm not touching that limbus. Rarely do you ever have to flatten that limbal zone with this design. It does happen occasionally, and you'll know it. If you have more vault in the limbus than you do centrally, you need to flatten, and it does happen, but it's very, very uncommon. Usually you'll be steepening it because you don't see enough green right there at the limbus region. I think that's about it for the limbal zone. Like I said, it takes me about 10 seconds to do a limbal zone. Have them look, lift up the top lid in primary gaze, check 4 quadrants, and then you just record on your sheet whatever you're taking notes on. Standard 1 steep, 2 steep. Oh, the other thing I was going to say is the reason we don't need a whole lot of clearance at the limbal zone, we recommend about 100 microns, which is kind of hard to measure, but it's about 1/3 of what you have centrally. The reason we don't need much clearance there is because while the central zone settles straight down and you lose clearance, the limbal zone, as the lens settles, the lens kind of settles down and out. And so the limbus is actually underneath kind of a steeper part of that lens as the day goes on. You don't tend to lose much at all limbal vault from when you put the lens in to when you take it out at night. So if you start with some green, you're probably going to end with some green. In other words, if you start with some vault, you'll probably end with some vault. So just being able to see some green, see some clearance there is all I need to feel comfortable. But don't ignore that zone either. That's probably the most ignored region of a scleral lens. Everybody wants to get to 300 microns of vault centrally. Everybody wants to check their edge. And the poor limbus gets ignored. But it's very important when it comes to making sure we don't get debris accumulation underneath that lens as the day goes on. The final thing is the scleral zone. If you fit an older generation scleral lens right now, like I said, I cut my teeth on the Jupiter. The edges were kind of a nightmare, and it took a lot of tweaking, and they were complex to tweak because there was a couple different curves you had to manipulate independently. The biggest difference between those older generations and the newer generation designs is the out-of-the-box edge. These edges fit so beautifully well with little or no adjustment. Once you get your central zone fit, it's absolutely amazing. But again, if you do have to make an adjustment, it's very easy to do. The edge is the gatekeeper of tear exchange, and tear exchange is important under a scleral lens, and it can be demonstrated very easily that we have it, and I'll get into that in a minute here, but we do need some tear exchange to get debris out, to get nutrients in, and to get some oxygen in as well. We get a lot of oxygen through diffusion, but there's probably some that comes through tear exchange. Just like on a soft lens, just like on a corneal GP, tear exchange can be very, very important. So for each of the 8 base curves in your fitting set, you had 5 15-0s and 3 16-5s. For each of those, you have 3 different lenses actually, because you have 3 different edges. You have a standard scleral zone, a 1 steep scleral zone, and a 1 flat scleral zone. So you'll always start with the standard scleral zone in the base curve that you ended up with, and then you can make adjustments from there. Outside of the fit set, you can also order in a 2 flat and a 3 flat scleral zone. So you can continue to flatten if you need to. I think I've used that 3 flat one time, but I do use a 2 flat on occasion. So the 2 things we're looking for, either a lens is too tight or a lens is too loose. You want the edges to lay nicely along the conjunctiva, and you can appreciate that just with the binocularity you get from a slit lamp, right? We get a stereoscopic view out of our slit lamps, and we can see, hey, is that edge lifting off? Is it digging in, or is it laying nice and evenly? There's a few kind of tricks you can use in order to make sure you have a good edge. A steep edge will show a couple things. One, it will show just impingement of that conj. If you look at the edge, it might be digging down into the conjunctiva, and the conj might be rolling up around that edge, and that's a good indication that, hey, we're digging into that conj and that's too tight. If you see that, you'll go to your fit set for that same base curve, grab the 1 flat edge and put that on the eye and see if that helps things out. Blanching is another common side effect of a tight edge. This is an extreme example up here, but basically we have blood flowing in from the periphery toward the limbus. A tight edge will impede that blood flow, and therefore you'll get blanching or a white band. This one's much more on par with what you'll actually see clinically with the newer designs if you do have blanching. Really faint white band underneath that peripheral edge there where that blood can't quite get through. You might see a little bit of redness interiorly where the venous system's backed up a bit as well. But if you see that again, go grab the 1 flat, put it on. That should rectify the issue. If it doesn't, order in the 2 flat. Rarely will you ever need to go to that 3 flat. One thing I'll say about a tight edge is that it's very comfortable to the patient when you first put it in. The edges are tucked down into the conj, so you don't feel anything when you blink at all. The lens does not move at all, but depending on how tight that edge is, between 1 hour and 8 hours into the day, these patients are not going to be very comfortable. And they have a lot of lens awareness and irritation and redness. And that's the first thing I look for if I fit a patient and they say, I can't wear this lens for at least 12 hours, and they're not a severe dry eye patient. The first thing I say is probably tighten up on you. Come in at the end of the day, let me look at it. I'll look at the edge, see if it's tightening up, and I'll go ahead and flatten and order a flatter edge. If I'm in a 1 flat, I'll go to a 2 flat. If I'm in a standard, I go to a 1 flat at that point. A couple of things you can do yourself to test out if it is adhering or not. I do this on every single patient. It's a spin test. Have the patient look up toward the ceiling, take your thumb, and spin that lens in a circle. It's harmless. It won't hurt the patient at all, assuming you have the proper amount of vault over the cornea. Spin that lens. It should spin very freely and very easily the first hour after insertion. Later in the day, you can get it tightened out a little bit, but you should always be able to spin it. If you get some resistance, you see a lot of conjunctival wrinkling underneath it, it's hard to spin, it's probably too tight. You're probably not going to have proper tear exchange. You need to flatten that edge out a little bit. So spin test takes less than 2 seconds to do per eye, and I do it on every single patient just to make sure that lens is moving easily and is not adhering. A good thing to do when they come back in for follow-up. So after dispensing, they come in. I always have them come in at the end of the day. I want to see how that lens is settled at the end of the day. You or your tech take a fluorescein strip while the lens is still in. They've been wearing it all day. Paint the surface of that lens with that fluorescein strip and give it between 5 and 7 minutes and go back in there, and you can actually see where the fluorescein is migrated underneath that edge, indicating tear exchange. And you can, A, establish that you still have tear exchange, which is a good thing, and then B, that fluorescein can then help you evaluate vault by making that gap between the lens and the eye nice and green, which makes it easier to visualize the vault. So a good thing to do at your follow-ups. If you have an OCT, that also works well. You can use the OCT to evaluate the edge and your central clearance at the follow-up when they get in before they even get into the room to see you. But the fluorescein strip works well if you don't have access to that. The opposite of a tight edge is obviously an edge that's too loose or edge lift. Unlike a tight edge, it's very comfortable when you first put it in because everything's tucked in nicely. A flat edge will actually cause instant awareness. It's not going to be painful, but they'll say, I feel it when I blink, and they can usually point to the area where they feel it under the top lid, under the bottom lid, or whatever it might be. And you look in, you can see the edge actually lifting off. And it might be only lifting off in one meridian. It might be lifting off, or one quadrant, it might be lifting off 360 degrees. This isn't as common to see something like this, but it's really easy to pick up on. And all you have to do is go to your fit set, same base curve, grab the one steep from that same base curve lens, pop it on there. They'll instantly say it feels better. If you're ever not sure, a lot of patients, especially mild to moderate cones at normal corneas, will require the same base curve on both eyes. I'll usually put a one flat on one and a standard on the other, and they'll tell the difference. They'll know which one's standard. That one will be more comfortable. Now, even if they have a little bit of awareness in the beginning, that's okay because these lenses all do tighten up throughout the day. But excessive edge lift and excessive awareness and irritation needs to be accounted for by going to the one steep. But if it's just a little bit loose, it'll tend to tighten up in the first hour there. And that's really it. So just really quickly to recap, we start with the C lens in our fit set. We look at our vault. If we have too much vault, we'll flatten our base curve down to B. If we don't have enough vault, we go up to D and then just keep following in that same order until we get that one-to-one relationship. Make sure you can see green at the limbus. Make sure the edge is laying evenly, not too tight, not too loose, all manipulated with flats and steeps, and your lens is fit. At that point, I go ahead and do my over refraction. I like to get an auto refract with auto Ks because I'll show you in a second that helps you detect flexure. I'll always do a spherical over refraction unless I know for a fact I'm going to have residual cylinder. In the case of a toric IOL or a normal cornea with over 3 or 4 diopters of regular astigmatism, that tends to shine through. But in your regular cornea, I'm doing a spherical over refraction, and you'll typically, even if you see some still on auto, a lot of times they'll kick that right out anyway. Save yourself the time and do spherical. You can add a front surface toric to these. I avoid that whenever possible though. Spherical lenses are so much easier, so much more consistent. Even if you lose 2 letters on a line of vision in your 20/20, the patients are typically still a lot happier than having to worry about a front surface toric. Again, flexure is something we need to watch for. These are big lenses, they're high decay lenses, they like to bend. A little flexure is not a bad thing. In fact, a little flexure is what really drives our tear pumping mechanism. That's what's going to move those nutrients in, the waste products out. That's what's going to allow us to not have stagnation of tears underneath that lens. But excessive flexure will obviously cause astigmatic symptoms. So it's something to watch for. And you can detect it a couple different ways, but the way I find to be most effective is just listening to patient symptoms. If they say my vision fluctuates a lot with a blink, or they describe astigmatic type symptoms like starbursting of light or trouble reading LED clocks and things like that, things with people with SIL would complain about, I go ahead and I thicken that lens up. We thicken it between 50 and 100 microns. I usually start at 50 microns, and you can just have the consultant do that for you. If you want to do it yourself, the center thicknesses are listed on the inside hood of the fit set, along with all the other parameters for each of your trial lenses. So you can do that yourself, but the consultants can easily pop that thickness on there for you. Measuring it, when you do over Ks on a spherical scleral lens, you expect your delta K to be 0, right? Because these trial lenses should be spherical. So anything over 3/4 diopter of delta K on auto Ks, or if you do manual Ks too, same thing, I'll go ahead and thicken my lens up there too. That might indicate flexure. And then over a diopter of with the rule astigmatism. So I'm at 125 or over a with the rule on an irregular cornea. I'll probably thicken it up there as well. Against the rule, it tends to be lenticular. Because of the way these flex with the blink, they'll induce more with the rule astigmatism. So everything you need to get started fitting sclerals, I think they give you enough to fit your first 3 patients in the Atlantis fitting set with everything except for cleaning solution. And for me, I use pretty much 100% clear care on all my sclerals. I have them rub with clear care on the palm of their hand for 5 seconds and then put it in the clear care overnight, take it out, rinse it, pop it in the eye, and it's ready to go. These lenses fit in the normal clear care cages. You don't need to buy any aftermarket special scleral lens, clear care vials, or anything like that. I think it helps hydrate better. It's so much easier now that all of our salines that we fill the lens with are pretty much single use. There are a few exceptions to that, but they're pretty much single use vials. So you don't have a lot of saline to rinse a lot of GP heavy cleaner off the lens. With the peroxide, you take it out, give it a couple quick squirts to rinse it off, and you can pop it right in. So that's my cleaner of choice. That being said, any GP cleaner works. So whether it's OptiFree GP, the Bostons, the Lobobs, the Unique pH from Menicon, all that stuff is obviously approved because these are GP lenses. It's GP materials that we're using. Like I said, it includes everything you need from fluorescein strips, dispensing towels. It'll give you 3 vials of saline. It'll give you inserters and removers, and obviously the lenses. When we talk about saline, the most common thing people are using right now is nebulizing solution. It's actually an inhalation solution used for breathing machines for people with like asthma and emphysema and things of that nature. You can write that as a prescription, and I've written out how to write it down here, including the NDC number that is the number the pharmacist can reference for that specific medication. I say in air quotes. But I find it really easy for patients to order it off Amazon as well. And it's called either the Addy Pack or Modudose, either one. They come in 3 mLs or 5 mLs. I opt for the 5, so you have a little bit more in each vial. They look like this. Picture over here, and it's just non-buffered, preservative-free saline. It's off-label in this situation, but it is very effective, and it's all we had for a little while there after they took Unisol off the shelves. We now have some new options. We have Lacropure from Menicon, which is single-use vials of preservative-free saline. We have Sclerofill from B&L, which is sort of single use. They're big 10 ml vials, which you can get a few uses out of, but they're still preservative free, so you have to be very careful about contaminations if you're going to reuse those. And then PuriLens is really a Unisol 4 replacement. If you remember Unisol 4 as a big multi-dose preservative free saline bottle you could get, it's pretty much the same stuff as PuriLens. It's now available, and that can be ordered right off Amazon as well. Lacropure, I have a Menicon store set up. You can do that for free, and then they send your brochures. Your patients go to your store. You get a couple bucks back when they buy it through you, but at least it gives them a way to buy Menicon products. I use ProGent a lot to clean these lenses with. I don't ever polish scleral lenses. I think the optics are really too refined these days, and the materials are too soft, so I just ProGen them at 6 months if they're really kind of getting gugged up, and I'll have patients purchase that if they're really heavy depositors, and they can buy that through the Menicon store I set up as well. A couple quick resources. I'll just point out scleralens.org, the second one. Highly recommend that website. That's the Scleral Lens Education Society. On their homepage is a video. It's a 10-minute video, and it's made for patients, but it works great for staff or even doctors who are new to sclerals. It talks all about carrying and handling and inserting and removing scleral lenses. I show that to every patient at their dispensing visit, and I recommend you do the same if you do a lot of these. GPLI.info is obviously another really great site, and they've really tailored to the scleral lens market over the past few years here. Something very cool offered by Excel I'll mention really quickly. If you're new to sclerals, your staff's new to sclerals, if you can line up 3 fits in a single day or more, 3 patients in a single day, they will fly a consultant out to you, and they'll actually help you fit those patients, teach you how to fit them, teach your staff how to do insertion removal, everything that comes along with it. They do that at no charge, assuming you have 3 patients, and you obviously have to buy those lenses. But other than that, it's a very, very cool option from Excel. And for attending the webinar tonight, if you use this code, AT627, if you buy a Atlantis fit set in the Paragon HDS material, you get your first fit free. And these lenses are $125 per eye for the standard lens, so it's a $250 value. Pretty good deal. There'll be an email coming out, I believe, with that promotion code in it as well. So If you've never used Excel, just in general, I can't recommend them enough. It's an employee-owned company. I've gotten to know a lot of them very closely over the past couple of years. You can tell it's an employee-owned company because they take a great deal of pride in what they do, and that's from the people who answer the phones to the consultants. There's an amazing amount of continuing education. You never wait on hold. You never talk to a machine. A person answers every time you call. It's really a great company to work with, and they do the full line of specialty contacts from GPs to sclerals to specialty soft. They have a flex lens, which is a great option for mild to moderate cones who need a soft lens who can't handle maybe a scleral quite yet or something like that. And then their Extreme H2O products are, I think, going to be game changers as well as time goes on. So that's all I have. Like I said, our next one will be on August 1st. We're going to get a little bit more into the customization and special design features for the Atlantis platform, including reverse geometry and multifocal front surface toric, toric haptics, things like that, that you don't come across a ton, but they're really helpful when you need them. And then we're going to do one of these probably every 4 to 6 weeks. We already have the schedule out, and I think you'll get an email with that schedule as well. That's going to cover a lot of things, everything from more scleral lens talk, troubleshooting with depositing, dryness, things like that, to going over the new keratoconus classification system that's been released. It's very cool and very helpful in grading keratoconus and deciding when it's time to consider transplantation. So that's all I have. Kathy, do we have any questions?
Not yet. Does anybody have any questions? I can either unmute you or you can type it in if you raise your hand. Nobody has any questions? Drew, do you have any other last comments?
No, one thing I just thought of, a question I always get is how long do they last? And I always recommend you replace scleral lenses once a year. Because of their high decay nature, they tend to deposit and scratch pretty darn easy. And after about a year, I usually recommend the patients dispose of them or use those as backups. And I always tend to get that question. I need to just put it in the presentation, but I always forget to do it. So that's all I have. So I appreciate it, Kathy.
I have a couple of questions coming up. Would like a course on proper billing of scleral lenses.
I think that's on the schedule. Go ahead.
Yeah, and we also have an ICD billing recording on our website as well, and one of our courses will cover that also?
Yeah, we're going to do that in December, but I know you guys just did one about a month ago that is available on your website that was really, really good, and I highly recommend that one too. But we will cover that in this series as far as billing and coding goes.
We have a question. What is the cost of the fitting set? The fitting set in the HDS material is $4.99 for a 24 lens set. And of course, you get the first pair free. Does ProGent cleaning tend to kill the tangible HydroPeg coating?
You know, that's a really good question. HydroPeg, which again, something we're going to cover a little bit later, is a new coating. It's actually a polymer that can be applied to the lens that makes them super hydrophilic. Really great for patients who can't wet lenses properly. Really good for any patient in general, just because it does a great job of maintaining surface wettability. They've approved 3 solutions now. It was only 2: Unique pH, Boston SimPlus, and ClearCare. SimPlus is a new addition to that approval list that you can clean lenses with. I'm not positive about ProGent. And that's something that if we get that guy's name or lady's name, I can definitely find out and email them the answer to that question. That's a good question there. But I will say the coating does wear off. I usually don't ProGent until 6 months in minimum, and I wouldn't worry too much about it at 6 months because the coating's supposed to last a year, but if they're already depositing, then something needs to be done anyway. And so I'm going to do something, and that could include ProGenting the lens. You can send the lenses back in to be rehydropegged, though. So that's another option, too, if it does start to deposit up by the 6 month point.
The next question is, can you show the slide that shows a proper fit one more time?
Sure can. Any of these will work. That's a pretty good one there.
We have, can you briefly can you briefly repeat what the preferred solution to cleaning the scleral lenses are?
Yeah, and like I said, my preferred solution is ClearCare. For just a standard scleral lens, it's any GP cleaner. So it could be Boston Simplus, Boston Advanced, Optimum by Lobob, Unique pH from Menicon, OptiFree GP. If you get that HydraPeg coating, though, the only ones that are currently approved with that are ClearCare, Unique pH, and Simplus. At least that's the last I heard. Simplus was added a couple months ago to that list. But again, ClearCare tends to be what most people are going to these days for scleral lenses. And I do encourage a rub with that as well.
Next question. We have a patient that is a high depositor, and she tends to come in once a month to have them cleaned. Other than Progent, do you have any other recommendations? Right now, we are just cleaning her lenses with a contact lens we're just cleaning her lenses with a contact lens sponge and an extra strength cleaner.
Yeah, I mean, as far as getting the deposits off, that extra strength cleaner works good. I use Dawn dish soap a lot, especially if it's a more lipid-based deposit. That's a perfect candidate for that HydraPeg material because that's what it's really made for, is to be super hydrophilic, resist depositing, and encourage water or wetting. So I would try next time you order one for them to order it with that HydraPeg coating on it. It's only available on Economac materials, but Optimum Extra is a really good GP material with a DK of 100 that it can be applied to. And then the other thing I'd recommend is probably having that patient purchase Progent, and probably it can just do that from home once a month. It used to only be in office that you could use Progent, but now it is available for patient purchase as well. But that'd be my recommendation.
Any other questions before we sign off? Drew, I think that is it.
Great. Thank you so much.
And thank you all for attending tonight. There will be a follow-up email regarding the webinar.